So you're covering the frozen section laboratory when you're called to evaluate a specimen on a 53-year-old male with a right brain tumor. That's all you know for now. Your PA is kind enough to make the following smear for you. And microscopically, this is about all that you encounter. It's not very cellular. You have a few capillaries coursing through the field. Surely there are some astrocytes in there somewhere, but is this normal? Is this neoplastic? What is this? How do you proceed in a case like this? Is it abnormal tissue? Negative for malignancy? Do you call it astrocytoma? Do you say, nope, I'm going to dig my heels in. This is non-diagnostic. Get me some more material. Or do you do something else altogether? Well, this presentation is intended to answer that kind of question. This is supposed to cover the fundamentals of intraoperative neuropathology, and for the next about 50 minutes or so, we'll be talking about strategies that you can use to improve your intraoperative diagnosis and to have more fun covering brain and spinal cord tumors with the neurosurgeons in the Alina system. Really, we'll talk some about the methods of intraoperative neuropathology, but there are a lot of things that don't go on in the histology laboratory, the grossing laboratory, that are important, including the MRI and the radiology that happens before the patient is even entertained for biopsy. I want you to understand something about what a generic PACS system is and how to use that. And then I want you to know really what the most common scenarios and pitfalls are in the intraoperative diagnosis of brain tumors. Finally, it's not trivial, but I want you to learn how to pronounce Eitan Bogard. He's one of our young neurosurgeons and a rising talent here in the Alina system, but nobody the first time pronounces his name correctly. So I've guaranteed him that I would try to teach my colleagues, and although it doesn't sound like the Dutch pronunciation, he pronounces it Eitan Bogard. Okay, so intraoperative neuropathology is all about smears. It favors smears far and above away frozen sections. The advantages of smears are that they use very little tissue, that you can really appreciate cytologic features. It's far, far better than permanent sections, or certainly of frozen sections in seeing those cytologic features. It's fast and it's very simple. The disadvantage is that you really can't sample the architecture. It's hard to infer from smears. Distinctions like infiltration versus circumscription are very, very difficult and best answered by radiologists, not by pathologists, when you're talking about cytologic preparations. Smears do, unfortunately, require a little bit of practice, and we'll show you some examples of good smears, and you'll have that in your mind's eye for what you're looking for adequacy in terms of smear preparations. There are some foibles with it. If you take too much material, if the smear is too thick, you can overstate cellularity and inject your own set of artifacts. Plus, smears are not very helpful when it comes to vascular malformations. Arteriovenous malformation, for instance, just is simply better studied on frozen section. Most things, though, whether they're dural-based or brain parenchymal lesions, really are better on cytologic preparation than they are when examined in histologic section by frozen section. Now, these are some examples of some really great smears that were done in our system. You can tell that the particles gave way readily, and they formed a nice oval region within the center of the smears. Even the smear on the far right here, that forms a beautiful oval here, although it flirts with disaster in terms of coming close to this frosted end, does a very nice job of actually spreading the material out. These smears, on the other hand, have various defects. It's simple, the smear procedure, but there are some foibles. It's easy to put your tissue down, disperse it with the other slide, but then road grader it off, sort of in the manner in this left-hand panel. If you're not careful, you can break the slide. You can apply too much pressure and cause all kinds of artifacts subsequently. This one actually has Scotch tape holding it together. You can use too much material, and I think that's one of the most common flaws, so that the two slides on the right hand of this panel are really too much material, too heavily glopped on into different areas. So frozen sections do have a role. Architecture is better appreciated, there's no question. So for instance, with vascular malformations, help yourself. However, even dural-based lesions like meningioma, I'll be quick to point out, usually smear just fine. So try that first before on dural-based lesions you resort to frozen sections. The disadvantages of frozen sections, though, are that they require a relatively large amount of tissue, that they have quite a number of artifacts that are injected. The crystal artifact is absolutely breathtaking. If you're forced to actually do a frozen section, I would recommend not using the isopentane in our system to freeze the actual material, but use a heat extractor, the metal piece that you can place on top of the specimen in OCT and freeze it that way. That tends to give fewer of the very heavy crystalline artifacts. And then furthermore, the other frozen section disadvantages are familiar to most people. Oligodendroglial tumors, for instance, tend to look more astrocytic, while the converse is true. Astrocytic neoplasms tend to look more oligodendroglial, ironically. So it's very difficult sometimes. Finally, the frozen section process alters the material, so even our immunohistochemistry doesn't work as well when we've been forced to freeze a sample. Now, not all frozen sections, or sorry, cytologic preparations are the same. Smears are greatly preferred. These are different from squash preparations or crush preparations. If you look at cytologic textbooks, you'll see that these are simply placing two samples between two slides and crushing them. Smear is actually smearing it and making that nice oval. So we don't use crush preparations, we don't use squash preparations, we use smears. Or occasionally we use touch preparations, particularly in the setting of the sella turcica. Pituitaries and pituitary adenoma touches like a dream. It's really a nice way to look at the material. That said, if it's not pituitary adenoma that you're dealing with, then, for instance, if it's a pituocytoma or some rare tumor within the sella, really the touch preparations are worthless. So I greatly prefer smear preparations even for sellar lesions. Let me show you some examples. So the histologic slide on the top of this panel is a smear preparation of pituitary adenoma. You can't make out individual cells, but you can see how there is a rich, lush staining pattern around the tissue particles. Those are all individual cells that are staining. Pituitary adenoma gives up cells readily, while anterior pituitary doesn't. The same phenomenon is readily apparent in the panel below, or below in the panel where you've got a touch preparation on the bottom slide that's giving up many, many cells in each touch. It's essentially identical information. Here, for instance, is a pair of cytologic preparations. They're both smear preparations. The panel on the top, the slide on the top, that is a pituitary adenoma. You can see again how rich and lush that is, how much material is divorcing itself from the particles and staining the overall oval pattern of the smear. On the bottom, conversely, anterior pituitary doesn't like to surrender its cells, so you get almost none of that. You've just got this dense little area where if you focused up and down, you'd be able to see adenohypophyseal cells. There'd be some heterogeneity to them. They're not the lush, rich, discohesive population that's seen in pituitary adenoma. Now, the actual preparation of smears in the frozen section laboratory requires some technique. And this is a slide given to me by Tarek Tihan, MD, PhD at UCSF in neuropathology. And he was very good at this. We much of our procedure in making smears is the same, so that examination of the gross specimen, step number one, is very important. You may ask, am I asking you to do this in a sterile fashion? No, usually not. Usually it's not necessary to study these sterilely. Of course, if there's a risk that there is, or a clinical suspicion of infection, then you'll want to examine them sterilely. Or if material is going to be handed off that might be cultured eventually, you'll want to handle it sterilely, but ordinarily that's not necessary. You select the pieces that are not simply normal brain. In this example, it looks like a core of normal white matter. Probably is not going to be that abnormal microscopically. But in a core with a single core, you can take portions of each end, for instance, and place them on the slide, not too close to the frosted end, so that when you make the smear, you have material that's lost in that way. And then you immediately fix it in formalin, or in the ethanol-formalin mixture. The method that Tarek used is slightly different than the method that I used, and or that I use. And I'm happy to show people the way that the cytopathologists at UCSF taught me to make smears. I know some people have good luck in making it in this fashion, but I do not, and I do not teach actually this exact method. So we can take it offline, and I'm happy to show people how to make a good brain smear. Now, when we're talking about the stains that I use in the ELINA system, H&E rules the roost. It's simple and straightforward, and people are accustomed to using it. The trouble with hematoxylin and eosin is that it tends not to be sufficiently concentrated by comparison with frozen sections. So you must let the material sit in the hematoxylin and sit in the eosin for longer than you would with a frozen section. Basically, I tell the techs to leave it in the hematoxylin for 60 seconds, not to rush it. And then for the eosin, anywhere between 30 and 60 seconds. Usually for simplicity, just 60 seconds is usually what I tell people, to leave it in the eosin. In theory, the histotech should know how to do this for all brain and spinal cord cases. In practice, they only do it for me, so be sure to remind them when you're encountering these on your own, or your stains are going to look pale and you're going to struggle to see the cytoplasm. So let's move ahead. Our next case is that of a 42-year-old male, and we don't have any clinical history. But we do have a beautiful smear. It's a nice oval. It's very well dispersed. You can see that even at 1x. And by golly, it's abnormal. Not just abnormal, but neoplastic, clearly astrocytic, with very well-developed cytologic processes and eccentric oval nuclei. Some areas are very cellular, and you even see little tiny bodies that are scattered around. They're smaller than a lymphocyte and represent fragmented nuclei of some kind, either karyorectic debris or perhaps apoptotic debris. But what these indicate in the majority of cases is the presence somewhere in the sample of necrosis, often pseudopalisading necrosis. Now I've started to allude to an algorithm. The first and very most important step is to decide, is this normal material or abnormal material? This is critical. If you can't progress beyond this, you've got to put on the brakes and get more information. The next step is to decide whether it's neoplastic or non-neoplastic. And the basic fundamental truth is that most of our cases are neoplastic. Beyond that, your third decision point is whether something is glial or non-glial. We can sometimes allude to a glial tumor being circumscribed or infiltrating, but really, for the most part, that's a determination that's best made radiographically at the time of intraoperative analysis. So we have to be aware of the radiology. And finally, it's nice to be able to determine grade as well. So, and grade is linked with things like circumscription and infiltration. So, bottom line is, we really need to know something about the clinical and radiographic findings in every single case. So we get some. This was a 42-year-old male with headaches and nausea. Well, that's not especially specific, so we dig harder. MRI has revolutionized intraoperative neuropathology. We as physicians have not had this much information at our fingertips, except in the morgue, actually, at the time of autopsy, when we could assay the whole brain at the same time. Now we have MRI to replace much of that work, and we can do it while the patient is still alive, and then furthermore, during the procedure. Sometimes the reports aren't available. Sometimes the patient is only being seen with a current intraoperative MRI that's queued up. So the actual images are available, but the report is not. So I'd like to walk you through the process of our PACS system. PACS stands for Picture Archiving and Communication Systems. In the Alina system, that means EMI Advanced Visualization. Sometimes it's also called EVMS. And at some point, I'd like to make a screen flow where I actually show people how to use EVMS to look at raw MRI images so that you get a sense of how these will be used. Stay tuned. We'll have that up hopefully within the next quarter or perhaps year. In any case, in this situation, we pull up the following MRI image. We see that there's a very large lesion within the right hemisphere, that it's irregularly bordered. It's got this irregular contrast enhancement, or so-called ring enhancing pattern, and that it's got this large heterogeneous signal void within the center of it. Now, a quick review on MRI for the people who don't think about this every day. T1, when you're talking about brain, is, as Tarek Tihan would say, anatomically correct. Gray matter is gray, and white matter is, well, if not exactly white, it's at least paler than gray. T2, on the other hand, is inverted, so that gray matter is pale and white matter is dark. T2 winds up being the much more sensitive, but less specific sequence. It shows off edema very, very well. Now, flare is usually a type of T2. The only difference is that it has an algorithm that essentially blackens out the CSF signal. It's like taking a magic marker and actually blackening out all the white that would be occupied by the fluid in the ventricle. This tends to have the effect of making it easier to look at the periventricular white matter. Now finally, gadolinium is the contrast material, and it's usually given in the T1 weighted sequence. That's because it contrasts better with the background brain in that sequence. So in our case, I've shown you the lower left-hand panel already. It's the T1 with gadolinium, showing this irregularly contrast-enhancing lesion. Notice that there's another T1 in the upper left-hand corner that doesn't have that strong ring-enhancing pattern because there is no contrast, but that is the T1 weighted sequence, the so-called anatomically correct sequence. T2 shows off edema exceedingly well, and you can see how our tumor is very pale, almost the signal of CSF within the ventricles. Finally, T2 with flare is just that special algorithm blackening out that CSF so that you can have better appreciation of this periventricular white matter. But the signal abnormality is essentially the same finding. Now you might say, and this is a legitimate criticism, it's all well and good, Bill, but I don't remember any neuroanatomy, and there's no report available, so no neuroradiologist has weighed in. What the heck do I do in that setting? Well, I would still encourage you to check the PACS system, preferably when you see the case on the list rather than when you're in a panic trying to, coordinate frozen sections with, a breast tumor that's coming in and a colon that's coming out and so forth. If you can check it earlier, that gives you an advantage. Plus, you're always welcome to call me, and we can walk through the PACS system and see if there's something available that we can talk about. There's two useful categories when a pathologist looks at a brain MRI. The first is, gosh, it's pretty subtle. In other words, you don't see any abnormality, or it's pretty small. Or, holy smoke, look at the size of that thing. You'll say to yourself, even I can see this big lesion. It's hard to imagine anyone would be able to miss it. The reason I want you to make that distinction is Bill's rule, which is essentially that a lesion is as normal microscopically as it is radiographically. In other words, if it's radiographically obvious and what you have is a sample that looks essentially normal or with minimal abnormality, then they're not in the right spot. So make some more smears, look at the gross very carefully and pick a different piece, but you don't have all of the information in that setting and don't make a diagnosis. So, and then if you've looked at the gross, you've made additional smears, and you're still in the same fix, then ask for additional material. So, in this setting, no problem. We have a radiographic abnormality that's big as all outdoors, and corresponding abnormality in cytologic preparation. So this was a glioblastoma, and I just called it a glioblastoma. Other okay intraoperative diagnoses would be high-grade glioma or high-grade astrocytoma. You have to ask yourself one question, one nuance when they're doing a biopsy only of glioblastoma. You can make the diagnosis cytologically and flat-footed call it glioblastoma sometimes. But remember, most central reviewers only review permanent sections. So if the patient is being enrolled in a trial, you want to make sure that you have enough material in the permanent sections. And these can be really small, so it's sort of an art form to make this guess. But even with a very small biopsy, you want to make sure that you've got necrosis or microvascular proliferation in those permanent sections. And again, examining the gross can help you out in those cases. Just as a quick aside, remember, there are only 3 flavors of infiltrating astrocytoma that sort of terminate in glioblastoma, our most common diagnosis in adults in infiltrating tumors. Diffuse astrocytoma is WHO grade 2 and has no mitotic activity, but is nevertheless infiltrating. Anaplastic astrocytoma is WHO grade 3 and has mitotic activity. So regardless of other appearances, pleomorphism, cellularity, it's the mitoses that really matter. And then finally, glioblastoma ordinarily has additional cellularity and so forth, but really what you need to establish the diagnosis is either necrosis, and it doesn't need to be pseudopalisating, and or microvascular proliferation. So, but you knew that. Now, in the setting of an irregularly contrast-enhancing or ring-enhancing lesion, I want you always, always to consider 4 things. While glioblastoma is certainly our most common diagnosis, I want you never to forget about metastases, abscess, and lymphoma. Now, metastases often get just resected outright anyway, so no real loss if you can't make that distinction intraoperatively. But abscess and lymphoma, both are not resected. Abscess will be drained, certainly, and often actually bypasses the pathology laboratory altogether in favor of the microbiology laboratory, which is fine with us. But lymphoma, you should never prompt gross total resection of lymphoma. That's not how it's treated. Biopsy is sufficient. You're really looking for diagnosis alone, and then chemotherapy, and if the patient's young enough, radiation therapy will be used to treat the lymphoma. So these distinctions are important. Now, I made a poster that the copies of which are available in the grossing areas around Abbott Northwestern and United Hospital and Mercy Hospital. So this will remind you of the lookalikes radiographically for glioblastoma and really what glioblastoma looks like. The big tumor in the middle or at the bottom of the poster is a big old butterfly glioblastoma of the kind we see in textbooks. And then at the top are the rogues gallery of radiographic mimics. Now, there are some pitfalls. Not everything that has some macrophages in the background is glioblastoma. So I want you to remember that things like stroke and demyelination and treated lymphoma and infection can have macrophages. And as a matter of fact, this was a cytologic preparation that we had where there's a macrophage here, if you can see the arrow, and then just to the left of it is a virally infected oligodendrocyte in a case of progressive multifocal leukoencephalopathy. So remember, macrophages alone don't make something neoplastic, or they certainly don't make it glioblastoma. So let's go on. The next case is that of a 56-year-old woman with back pain. Your PA makes a beautiful cytologic preparation for you. It's a very well-distributed smear. Particles seem to be holding together quite a lot. You diligently check the PAC system and you identify this lesion here. It's a very discrete lesion, and when you look into the report, you might find out that it's intradural extramedullary. Lo and behold, you get a very beautiful smear when you look microscopically and you see characteristic features of meningioma. Although this field doesn't contain nuclear holes, which are also often identified. Beautiful oval nuclei with smooth nuclear contours, evenly distributed chromatin, tiny little chromocenters, and then very satisfyingly, you've got these whorls that are characteristic, not always present, but characteristic of meningioma. Now, meningioma is a classic. It's very, very commonly encountered in our practice. Ordinarily, you hear report of or see dural-based lesions. So this is an example of plaque-like meningioma residing along the left convexity in a very, very long fashion. They can look like that. They can be more ball-like, sort of a large, still durally based lesion, uniformly contrast enhancing. You can see them in multiple profiles. Here's a sagittal where there's a very sharply demarcated tumor pushing into brain from above with this little bit of a dural tail on it. That's classic for meningioma. And not everything that looks like meningioma radiographically is meningioma. So think about things like hemangiopericytoma and the solitary fibrous tumor group. There really is overlap between the two, particularly in the brain, or within the skull. Metastases certainly are entitled to be durally based, and a rare lymphoma can also be durally based, so be aware of that. And then really, especially within the cerebellopontine angle or in the spinal cord, schwannoma is your chief differential diagnosis. Now, meningioma has a ton of different patterns, and it's usually not worthwhile to make those distinctions on cytologic preparation. Grading is complex and also is fraught with peril when you have a very small sample of a larger lesion. So I don't recommend typing meningioma, nor do I recommend grading meningioma intraoperatively. If asked, I think it's okay to say, well, I do see or I don't see atypical features, but then know something about what those atypical features are. The easiest, most readily identified atypia in meningioma is mitotic activity. So if you see mitoses within the smear, you may indicate that there is some atypia based on elevated mitotic activity in cytologic preparation that you've done. Once in a blue moon, when we get off a really nice discrete meningioma and you can see that there's some adherent material on the surface, I'll do a frozen section of that and be able to demonstrate brain invasion on that basis. Basically, meningioma on 3 sides of brain is diagnostic of brain invasion. But ordinarily, it's a fragmented sample, and you just don't make that diagnosis. So comfortably give the diagnosis of meningioma. If asked about the presence or absence of atypia, be honest, tell them yes or no, that you think there are too many nucleoli, but this is really not, grading is really not to be performed intraoperatively. So, case number 3 was a classic example of a meningioma. We also have a poster that addresses the dural-based lesions like meningioma that's available at the frozen section areas, and it just reminds people that meningiomas have a variety of positions and appearances. They can be cystic. Hemangiopericytoma can certainly be in the differential diagnosis. Schwannomas in the differential diagnosis, particularly in the spine and the cerebellopontine angle, and they can be multiple even. I think at the very top of this poster we've got a case with multiple meningiomas. So let's move on to case number 4, who was a 19-year-old woman with a left cerebellar tumor and cyst. We've got, again, a really nice set of smears. Ovally dispersed, they seem to be holding together quite well. That's interesting. But nevertheless, these are very, very well-made smears. Most of the material looks like this, where you've got areas that are very hypercellular, with interspersed areas of very low cellularity. At higher power, you see here the lower part of the field is occupied by these small, densely populated cells, and the upper part of the field is much less cellular. And there's something going on right at 12 o'clock there, a big cell of some kind, maybe a ganglion cell, we're not sure. We look hard, and we see this pink, ropey, waxy material in some of the areas that are less cellular. And you say, oh my goodness, this is Rosenthal material. What exactly are we dealing with? Is this a pilocytic astrocytoma? We know that Rosenthal fibers go with pilocytics. Well, we take a step back. And while 19-year-olds certainly get pilocytic astrocytoma, most of this material is not tumor. And as a matter of fact, only one fragment in these 2 smears had features, and these were different features from the rest of the smear. A very cohesive neoplasm with hyperchromatic nuclei, not well developed cytoplasmic processes, and so we don't make a diagnosis right away. We think about this carefully. We look at the imaging. It's a cystic lesion. This is a sagittal T1 weighted MRI of the brain, showing a cystic lesion within the posterior fossa and a little contrast-enhancing mural nodule. In another view, in the coronal plane, we see, again, a big cyst and a little tiny contrast-enhancing nodule. But lo and behold, when we look in axial plane, we see that, yeah, well, there's a cyst, and there's some complex nodularity in the contrast enhancement, maybe kind of a dumbbell-shaped cyst here. There's actually another contrast-enhancing nodule here that's not contiguous with the cyst. And if you'd page up and down through this MRI, you would have seen other examples of this. So this is just highlighting the contrast-enhancing nodules. So in fact, with a little bit of digging, we found out that this woman's grandmother had von Hippel-Lindau disease and had renal cell carcinoma. And our patient has capillary hemangioblastoma and, unfortunately, von Hippel-Lindau. So the Rosenthal fibers that we were seeing were really just a red herring. Much of the background brain was actually just cerebellum. And so on the left of this field in this photomicrograph is showing the capillary hemangioblastoma. And on the right side is a field of dense astrogliosis with ropey pink Rosenthal material. So this really leads us into the posterior fossa group. We've talked about irregularly contrast-enhancing lesions already. You can certainly get those in the posterior fossa, but they're pretty uncommon. Glioblastoma happens, but it is pretty uncommon back there. So usually when we're called to the gross lab for posterior fossa, we're talking about cerebellopontine angle lesions. We're asked schwannoma versus meningioma, or a variety of other characteristic posterior fossa lesions, including pilocytic astrocytoma, medulloblastoma, ependymoma. Those 3 are classic in pediatric populations. And then hemangioblastoma, which is a nice example in this, nicely demonstrated in this case. Now, hemangioblastoma ordinarily presents in older adults, sort of middle and older ages, rather than in a 19-year-old. So it's easy to understand how we might jump over this. Without the history of von Hippel-Lindau in the background of this patient, it becomes a much more difficult intraoperative diagnosis. So there are some pitfalls in the cerebellum. Rosenthal gliosis happens there with any long-standing lesion. It actually happens also commonly in the suprasellar region and in the spinal cord. So be careful. Rosenthal gliosis is not necessarily indicative of neoplasm. Granule cells, those little tiny cells, can be mistaken for a variety of things, and often are mistaken for a variety of things, including lymphoma or chronic inflammation, and occasionally even medulloblastoma. So if you get a sample from a child's posterior fossa and it's very cellular, look very carefully to make the distinction between granule cells, which are ordinarily not ugly and mitotically active, and diseases like medulloblastoma. So in just generally speaking, from a low power view, 4x kind of view, it's really helpful to see sort of the biphasic granule cell layer and molecular cell layer pattern with interspersed Purkinje cells. The Purkinje cells are often destroyed, but when they're present, they're really helpful. So we've got a classic pattern in this photomicrograph where you've got lower half with granule cells, upper half with molecular layer, and then just pulled away from its usual seat here right at the boundary is a pair of Purkinje cells. So, all right, we're circling back to the beginning. Let's talk about our case where we had a smear. Now in retrospect, this is not a great looking smear. The material was placed here and then road graded to the end, so we don't have a really very good look at this. We look very longingly at this material, and it's that pink and pale dappled pattern that's often just normal brain. These endothelial cells and this delicate capillary don't mean anything. Capillaries are present in brain, and there's not really even enough here to call astrogliosis comfortably. You just don't have enough. So what did you want to do? Just call it abnormal? No, probably not. Call it negative for malignancy. It's not my job to really coach the neurosurgeon. I think they know what they're about. That will inspire, by the way, a pretty hostile response. Call it astrocytoma. Really go out on the edge. Well, you may know something about the imaging, so, well, it's probably there, right? It's an infiltrating astrocytoma, so, it's got to be there somewhere, a few of those cells. Say, okay, well, it's non-diagnostic, get me additional material, or none of the above. And I would argue, actually, in this setting, it's none of the above. You've got more work to do. Following a single smear only, you really need to look at the gross. You need to see, does this all look like benign, bland, white matter and gray matter, or is this actually looking like tumor? Tattered, yellow, rotten brown, mucoid stuff that you might do additional smears on. Check the imaging. Find out what the PAC says, and see whether it's big as all outdoors or so subtle that you can barely see it. And then check clinical notes and that sort of thing, and try and figure out. In a couple of minutes it takes you to get into the electronic medical record and the PAC system, you can learn volumes and really, really keep yourself from stepping on a lot of landmines. So this gentleman with a 53-year-old was a 53-year-old with a right temporal tumor, had an MRI showing an irregular, contrast-enhancing, infiltrative appearing lesion. He had generalized tonic-clonic seizure following months of episodic bitter smell and taste and some confusion with emotional lability and flashing lights. These are all sort of cues that say that perhaps there's some seizure activity going on. When you look at the actual imaging, you say, oh, well, I can see this. I might not know everything about it, but it's an irregularly contrast-enhancing sort of brain parenchymal lesion, seen here in the T1 weighted image with contrast on the left and the T2 weighted image on the right, which shows a corona of signal abnormality that is edema. It's not necessarily neoplasm. So if a surgeon is operating and biopsying actually this cloud of edema around it, you may appreciate no increased cellularity. It may be impossible to make a diagnosis. So what you really want to encourage is sampling of this deeper, more sort of radiographically abnormal area. So this will not cut the mustard. This is not diagnostic. It does not follow Bill's rule that something should be as abnormal microscopically as it is radiographically. This, on the other hand, is pay dirt. This is abnormal. That's our first rule, right? Determine, make a distinction between normal and abnormal. It's abnormal. It's neoplastic. It's emphatically neoplastic. These look like they're all part of the same process. It's also emphatically glial. And you have the satisfaction of seeing real atypia here, hyperchromasia, some little tiny fragmented nuclei. You can start to guess that in this context, in this age group, with this radiographic appearance, that this is a higher grade astrocytoma, infiltrating astrocytoma. And this was borne out. The permanent sections showed the first 4 samples where the cytologic preparation was identical, was normal and bland, showed nothing. And then we finally had enough material in cytologic preparation in the 5th sample to be comfortable saying, yes, this is neoplastic and astrocytic. Not a lot to go on, but in the presence of necrosis in the permanent section, we're in comfortable ground saying this is glioblastoma, this astrocytic neoplasm that's infiltrating radiographically with necrosis and this degree of atypia is perfectly satisfying as a diagnosis of glioblastoma. So, so many ways to fail, but it's funny, it's not failure of knowledge, it's mostly failure of process. It's not just checking the reasonable things and behaving like a physician. We can fail because we didn't check the imaging. We can fail because we called it diagnostic or suspicious when it was just vague. We could have gotten cold feet, and I've made this mistake myself where, yeah, I'm not convinced there's something wrong here, but just give me one more for the road and I'm sure you'll get it, right? It's a leap of faith when you say that, and be darn sure that that last piece is going to have the pay dirt, or don't put yourself in that situation. Finally, if we hadn't made that first critical distinction, if we hadn't said, when making the distinction normal or abnormal, I can't call this abnormal. I can't, if you jump over to just the presumed notion that it's abnormal, you're really doing a disservice, because neurosurgeons are people, and stereotactic equipment does fail. It doesn't always put them in the right position, and even the best neurosurgeon has been in this position. So where they're giving you non-diagnostic material, so help them out, be strong, and try and enjoy the process. It's a great deal of fun. We have a lot of resources at our beck and call. There's a couple of papers on MRI and brain tumors for those who are interested in looking them up. They're classics by Peter Berger in the Archives of Pathology and Laboratory Medicine. Berger has his own book on frozen section study that looks like this, that's available. And it's not his finest work, but it works really well in the frozen section laboratory. He actually relies more on frozen sections than some neuropathologists. I tend to rely very heavily on smears and the cytology. For my money, Joseph, in his diagnostic neuropathology, smears, wins the prize for the best, sort of most useful, rapidly used textbook that can be used right in a frozen section laboratory. And then finally, just sort of, although it's not all that old, it's already outdated because of the rapid advances in brain tumors these days, the Blue Book from the WHO is an absolutely critical piece. And if you need any clarification, it is a dense assembly of the most important facts. It's not great in all aspects. The meningioma grading description remains, even in the latest edition, arcane and very poorly put together, sort of spread apart, but remains an invaluable resource when you're looking at brain tumors. So thanks very much for your attention. If you have any questions, just give me a holler. My email is a great way to go, or my mobile phone is there, and I hope this makes you a little more relaxed when it comes to approaching the brain tumors. They wind up, ironically, being, although they seem like such high stress situations, they wind up being simpler than a lot of things, way simpler than many, say, GI tumors that come out of the frozen section laboratory, or gynecologic tumors, or things that can really get complicated fast. So they're often very stereotyped, and there's a very satisfying algorithm to follow in treating them, or in looking at them in the frozen section laboratory. Thanks.